We all know that trigger finger is a condition easy to be diagnosed and to be treated. And many works also on a quite large number of patients has been done concerning the different procedures. In our unit, we reviewed about 4,000 open trigger finger release. And what we noticed was that in 20% about of the patient, the major complaint was incision site discomfort, and in about 170 patients, scar retraction. I want to underline that every single patient treated in our unit is obliged to undergo occupational therapy and physical therapy protocol before operation. As regards to the technique, we choose this one, talking with some colleagues from Japan at first, to try to minimize the problem of the discomfort at the level of the incision site. These are the instruments that are used for the procedure. We will see in details afterwards. This is the way anesthesia is performed, very small amount of anesthesia at the level of the incision site that has to follow the flexor tendon lines. And this is a video that shows the procedure. There are a few advantages. One of the main advantages is being less aggressive procedure can be easily performed also in 3-4 fingers at the same time. The two incisions are one at the level of the distal digital crease and the other one at the level of the proximal palmar crease. 15 blade is used that we go with the blunt dissection has to feel the tendon layer. We just can feel it underneath. This is done both distally then proximally, without widening with the mosquito incision. This is a dissector that helps us in making the right path to the distal portal. And then we insert this cannula that has a window. The pointer, no problem. If that has a cannula, okay, that we will see later on. Okay, underneath there's a window. Now we clean up a little with the cotton, and then we put the 1.9 optics in here, and we can see, of course, I put one at the point which is better possible to visualize the A1 pulley here. Sometimes there's much more synovitis, but with a couple of maneuvers it's possible to see better. We put inside this retrograde nape, and we cut both sides of the pulley, as is possible to visualize very well the structures, the tendon sliding, as well as nerves, eventual collateral nerves around this area. This is right after the operation. And as regards the post-operative protocol, of course, immediate active motion is allowed, and the dress is removed after 4 or 5 days. As regards the post-operative protocol, in all our patients, we put the dynamic splint and extension at night for 1 month, 3 digits during the day. The first week, active and post-op standard exercise are encouraged, while after the 7 days, we increase load as regards post-op rehabilitation protocol. From October 2005 to October 2007, 227 patients for 232 digits were treated with 54 years of mean age. In 145 cases, the right hand was involved, in 88, the left one. This is the distribution of the fingers involved. 5 patients underwent bilateral endoscopic release, not at the same time, by the way. And these are the associated diseases that were treated at the same time. And this is the average procedure time, about 4.5 minutes. All the patients were evaluated with the VAS, with visual analogic score, and with a table created by us that considers the daily activities, working activities, VAS, and the satisfaction of the patient, both from functional and aesthetic after the operation. This chart was given before at 7, 40, and 90 days after operation. There were no infection, no major complication. In 16 patients, there was dysesthesia for an average of about 7 days. In one patient, there was the lesion of the collateral sensitive nerve, and this was the second patient that was operated. So the complication was related to our inexperience in doing this procedure. These are some of the results. This is bilateral thumb release, and these are other, as you can see here. This was about after 1.5 months. This is an evaluation done by one of our therapists that shows how this procedure, the endoscopic procedures, give much advantages, especially concerning edema, pain flexion within the first 7 days, and pain extension of the proximal interphalangeal joint and scar discomfort after the 7 days. In conclusion, this technique gives definitely less scar painting, give a short and faster return to daily activity. Of course, has a higher learning curve and high cost of the instruments. We have to take care as regards paresthesia due to stretching of the digital collateral nerves. As regards the thumbs, we perform this procedure at the beginning also for regards this digit, but nowadays I left this to the open approach as we were used to do before, because the advantages is not so much compared for the one for the long digits. Thank you very much for your attention.